Lead poisoning remains a silent but serious public health issue, especially for young children. Even low levels of lead exposure can impact brain development, behavior, and overall health. Today we'll explore a real case of a 4-year-old girl diagnosed with lead poisoning and discuss the critical steps in identifying, managing, and preventing lead toxicity. Stay with us as we uncover essential information that every parent, caregiver, and healthcare provider should know. Subjective. A 4-year-old female with a history of autism spectrum disorder and developmental delay. Initial capillary or fingerstick blood lead level was 65 micrograms per deciliter, and the confirmatory venous lead level was 66 micrograms per deciliter. The family resides in an older home and frequently visits the grandmother's house, raising concern for possible lead-based paint exposure. No acute symptoms were reported. Caregivers state the patient is at her baseline. Laboratory findings indicate iron deficiency anemia with a hemoglobin level of 9.3 grams per deciliter. Objective. Heart rate, 141 beats per minute. Respiratory rate, 24 breaths per minute. Temperature, 98.42 degrees Fahrenheit oral. Oxygen saturation, 96% on room air. Laboratory results, venous blood lead level, 66 micrograms per deciliter. Hemoglobin, 9.3 grams per deciliter, consistent with iron deficiency anemia. Imaging abdominal X-ray shows no evidence of radiopaque lead-containing foreign bodies. However, there is a significant colonic stool burden present suggestive of constipation. Assessment: severe lead poisoning, confirmed venous blood lead level of 66 micrograms per deciliter. Iron deficiency anemia, likely secondary to chronic lead exposure. No acute encephalopathy or symptomatic lead toxicity at present. No evidence of acute lead ingestion from foreign bodies, as indicated by the negative abdominal X-ray. High-risk exposure history, with prolonged environmental exposure in a lead-containing environment. The plan includes initiating chelation therapy. First, we will start with oral succimer, also known as dimercaptosuccinic acid, or DMSA. The dosage will be 10 mg per kilogram by mouth 3 times daily for 5 days, followed by twice daily for a total of 21 days. In addition, we will begin intravenous calcium disodium ethylenediamine tetraacetic acid, or Cana2-EDTA. The dosage for this will be 75 mg per kilogram per day, as a continuous intravenous infusion for 5 days. We will monitor for nephrotoxicity by assessing urine dipstick testing and urine-specific gravity measurement every 8 hours. Next, supportive care is crucial. We will initiate multivitamin supplementation to support overall nutrition. Metamucil or psyllium fiber wafers will be given daily to prevent worsening constipation. Iron supplementation will be administered to correct iron deficiency anemia. Lastly, we will ensure adequate hydration to support renal function throughout the chelation therapy. Lastly, environmental exposure management is essential. We will assess the patient's home for lead hazards and coordinate with public health services for lead exposure mitigation. Additionally, we will provide family education on strategies to minimize future lead exposure. Monitoring and disposition are crucial steps in managing lead toxicity. The patient will require inpatient admission for at least 5 days while receiving intravenous EDTA. During chelation therapy, we must frequently monitor renal function with urine-specific gravity and kidney function tests. After completing IV chelation, we'll reevaluate the hospitalization status. If the patient remains stable, oral succimer therapy can be continued on an outpatient basis. Post-discharge, it's essential to ensure follow-up with pediatric toxicology and primary care. Follow-up is an integral part of the treatment plan. We will repeat blood lead level testing after the completion of chelation therapy to assess the efficacy of the treatment. Understanding lead toxicity is vital for effective health management. Lead toxicity remains a significant public health concern, particularly in children, due to its potential to cause serious neurological and systemic effects. Exposure to lead can occur through contaminated water, old paint, soil, occupational exposure, and imported products. Lead poisoning is categorized into mild, moderate, and severe toxicity based on blood lead levels and clinical manifestations. Mild to moderate lead toxicity is identified when blood lead levels are greater than 5 micrograms per deciliter. Early detection and prevention are crucial in managing lead exposure. Steps include an environmental evaluation to assess the home for lead-based paint, contaminated dust, water sources, and potential industrial exposures. Occupational and hobby-related exposure should also be evaluated, especially if the patient or family members work in industries involving lead, such as battery manufacturing, construction, or smelting. Hobbies like stained glasswork, ceramics, or shooting sports should also be considered. Additionally, a dietary assessment is important. Encouraging a diet rich in calcium, iron, and vitamin C may help reduce lead absorption. Chronic lead exposure, even at lower levels, can result in a range of health issues, particularly in children. These include neurodevelopmental effects, such as lower intelligence quotient scores, behavioral problems, attention deficits, and cognitive impairment. Gastrointestinal symptoms can also occur, including intermittent vomiting, abdominal pain, anorexia, and constipation. Systemic symptoms may include fatigue, headache, drowsiness, insomnia, hypertension, myalgias, arthralgias, and anemia, which is often microcytic with basophilic stippling in red blood cells. Most asymptomatic patients with mild to moderate lead exposure can be managed on an outpatient basis, provided lead exposure is eliminated. If symptoms develop or blood lead levels are high, additional interventions may be necessary. Chelation therapy is recommended for children with blood lead levels equal to or greater than 45 micrograms per deciliter, and for adults when symptoms are present or blood lead levels are equal to or greater than 50 micrograms per deciliter. Chelation agents include oral succimer, which is the preferred first-line oral chelation therapy for outpatient treatment, and D-penicillamine, which is considered a second-line oral chelation agent primarily used in pediatric cases where succimer is not available or tolerated. Regular blood lead testing is essential. Follow-up testing is required to monitor progress after chelation therapy. Lead-induced iron deficiency anemia should be addressed with iron supplementation. Abdominal X-rays should be performed if acute lead ingestion is suspected to identify radiopaque lead-containing foreign bodies in the gastrointestinal tract. Patients with mild or moderate lead poisoning should be followed closely to ensure declining blood lead levels and resolution of symptoms. Severe lead toxicity, which occurs at blood lead levels greater than 40 micrograms per deciliter, affects multiple organ systems, including the nervous, renal, gastrointestinal, and cardiovascular systems. Lead levels and their associated effects can vary significantly. At levels greater than 40 micrograms per deciliter, chelation therapy is typically required. When levels reach 60 to 80 micrograms per deciliter, patients may experience gastrointestinal symptoms such as severe abdominal pain, nausea, and vomiting, as well as early renal impairment, also known as subclinical nephrotoxicity. Levels above 80 micrograms per deciliter can result in serious lead intoxication, including nephropathy and neurological effects like confusion and altered mental status. At levels exceeding 100 micrograms per deciliter, there is a risk of encephalopathy and neuropathy, requiring urgent treatment. Management of severe lead toxicity. Hospitalization is required for children with blood lead levels equal to or greater than 70 micrograms per deciliter. Also, patients with symptomatic severe lead poisoning need to be admitted, and individuals with encephalopathy or severe neurological manifestations should be hospitalized as well. Whole bowel irrigation. If lead-containing foreign bodies are identified on radiographs, whole bowel irrigation using polyethylene glycol solution should be performed to accelerate lead elimination. Chelation therapy for severe toxicity. Oral succimer is used for children with blood lead levels less than 70 micrograms per deciliter and no signs of encephalopathy. Parenteral chelation is required for children with encephalopathy or blood lead levels equal to or greater than 70 micrograms per deciliter. Intramuscular dimercaprol, or BAL, should be initiated, followed by intravenous calcium disodium edetate or Cana-2-EDA for enhanced lead excretion. Neurological and supportive care. Severe lead poisoning can result in seizures, coma, and increased intracranial pressure. Management includes seizure control, First-line treatment involves intravenous benzodiazepines. For refractory seizures, a barbiturate-induced coma may be required. Cerebral edema management may involve controlled ventilation, mannitol, and/or dexamethasone. It's important to avoid lumbar puncture if increased intracranial pressure is suspected. When to seek immediate medical attention. Patients with symptomatic lead exposure or a history of significant lead ingestion, such as ingestion of a lead figurine, contaminated jewelry, or leaded paint chips, should receive emergency medical evaluation. If ingestion is confirmed on radiographs, whole bowel irrigation or surgical intervention may be required. Asymptomatic patients with confirmed exposure but no lead-containing foreign body in the gastrointestinal tract may be discharged home with close follow-up. Long-term considerations and public health interventions. Severe lead toxicity has long-term neurocognitive consequences, particularly in children. Persistent exposure is associated with intellectual and cognitive impairment, behavioral disturbances, attention deficits, and learning disabilities. It can also lead to decreased visual motor coordination, peripheral neuropathy, such as wrist drop, and renal impairment and chronic kidney disease. Public health and occupational considerations. All cases of childhood lead poisoning should be reported to public health authorities for home assessment and intervention. For occupational lead poisoning, notify the Occupational Safety and Health Administration or OSHA to ensure workplace compliance with lead exposure standards. Environmental intervention is critical to prevent re-exposure. Families should be counseled on lead-safe home practices, including lead abatement programs for homes built before 1978. Proper hygiene practices such as frequent hand washing and avoiding contaminated clothing, the use of filtered water if lead-contaminated water sources are identified. Conclusion: lead poisoning is preventable, and early intervention is key to reducing its health impact. Identifying lead exposure sources, monitoring blood lead levels, and implementing appropriate chelation therapy when indicated can significantly improve patient outcomes. Public health involvement is essential in addressing environmental risks and preventing further exposure, ensuring a safer living environment for affected individuals.